Dear friend and colleague, it's a pleasure to get together today on our share opinion in our respective and recent publication in GI Oncology Triage in COVID time. Let's start with a short introduction with you, Benjamin, and then from our side in Fleming Institute team.
Sure, my name is Dr. Benjamin Weinberg. I'm an assistant professor of medicine at Georgetown University in Washington, D.C. in the United States. I'm a gastrointestinal medical oncologist, and I specialize in the treatment of patients with colon and pancreatic cancer.
Hello, I'm Dr. Juan Manuel O'Connor from Fleming Institute in Buenos Aires, Argentina. I'm medical oncologist, head of the Department of GI Oncology in our center. Please.
And I wanted to thank you both for the invitation and introduction to have this international discussion, a bridge between Latin America and the United States. It's thrilling to have this opportunity. It was also very interesting to find that both of our papers about our experience in the COVID era included a mention of Immunoscore, which I think we're going to get to in a little bit. But first, I just wanted to ask, how has the COVID crisis impacted your care for cancer patients in Argentina?
Yes, indeed, very interesting. We published in the same journal as your point of view was aligned with it made sense with yours. The COVID situation in our region, Latam, is a big concern right now because we have the largest number of cases currently being the main focus of the pandemic. And also in our country, the number of infected people is increasing, and the last official report showed more than 6,000 new cases and roughly 150 deaths per day. So probably we are in the top of the curve, but we don't know exactly. Fortunately, the health system has not been saturated in our country, and the mortality rate remain low in our country. Some societies involved in the treatment of patients in our country developed some guidelines and recommendations for the management of our patients. At our cancer center, for example, we are reassuring people, we are screening everybody as they come in with at least a minimal triage. All the faculty and staff are wearing masks at all times, and we are also developing some local recommendations and platform for telemedicine. But I think that in general, our strategy is to continue to provide the best possible cancer care in patients who, despite the pandemic, need to be taken care. Our approach are pretty well complementary indeed. Your group wrote a white paper with biomarker of precision medicine helpful in COVID area, and we looked into range of COVID oncology guidelines. Ben, could you give us an overview of your experience with the immune response assessment tool that you highlighted in your publication and then in your talk? How did it come to you to include in your white paper recommendations?
Sure, that's a great question. So, going back to what you were saying a second ago, I think what's paramount is that we don't lose sight of cancer care just because we're in a pandemic, and that cancer care is really not a luxury. It's really something that is a standard practice, and giving things like adjuvant chemotherapy after colon cancer surgery, we know can save lives, and we don't want to compromise short-term risk of exposing patients during the COVID era and then losing out on the long-term benefit of more patients being cured from their cancer. So can we come up with better strategies to help mitigate both the short-term and long-term risks to find a balance? And there's a couple of technologies that are being used more and more to help risk stratify patients, especially after colorectal surgery, to really know who's could really benefit from adjuvant chemotherapy and who may not. And those are technologies like circulating tumor DNA, but also technologies like Immunoscore, being able to understand the T cell subsets and densities in resected colon cancer tissues, and then using their algorithm to help generate an Immunoscore, which has been shown to be very predictive of benefit from chemotherapy and also very prognostic, and really should probably be included in our routine staging design as it has been in other countries. So our experience goes back the last couple years already using Immunoscore, mostly for patients with stage 2 cancers, where based on traditional clinico-pathological characteristics, we're sort of on the fence about, one, recommending chemotherapy, and two, if we are going to recommend chemotherapy, how intense a chemotherapy regimen to recommend, whether we're recommending sort of single agent fluoropyrimidine or doublet with oxaliplatin. So I found it's been helpful, and especially in patients who, for instance, are T4N0, thought to be a high risk because of their T4 disease, but with no other traditional high-risk features, lymphovascular invasion, obstruction, perforation, et cetera. And I found it's been helpful in actually using Immunoscore to show patients that their risk really becomes close to a stage 1 if they have a high Immunoscore, and obviating the need for systemic chemotherapy. For stage 3 patients, it's a little different. There seems to be a suggestion that a higher Immunoscore actually means maybe we should be exposing these patients to longer durations of chemotherapy, 6 versus 3 months. Whereas with the results of the IDEA collaboration, we're now seldom actually giving 6 months of therapy for stage 3 patients. But those are the avenues where I found Immunoscore to be helpful. But what about in your region? How do you approach these patients using different risk stratification? And how do medical oncologists believe in the early phases of management and prevention of metastasis using these types of precision medicine tools? And do you work with your surgeons and your oncologists together in sort of a multidisciplinary setting, or are these sort of more isolated decisions that you all make?
Yes, Ben. Okay, let me say we are very interested in using Immunoscore in early stage colorectal cancer because allow us better stratification for our patient. You know, the cooperation between surgeons and medical oncology is also important because both disciplines attend the multidisciplinary teams, and the input for the MDT with a file form and more information and more accurate information status of the tumor and patient risk group is of high impact in appropriate and documented decision making for our patient. Oncology care, as you know very well, has become pretty much a team science, and we believe that MDT discussion and using this type of precision medicine tools, we are improving care and quality of life. So to sustain your point, Ben, in fact, we are also happy to know and to see the international clinical management guidelines include now the Immunoscore in their recommendations for localized colon cancer that recently published the ESMO guidelines with the new and very important information based on some precision medicine tool.
Right, so our approach is very integrated with our pathology department, and so most of the patients that are referred to us in the locally advanced, like non-metastatic setting, are internally referred from our hospital, and so the pathologists have the tissue ready to go. And so we basically fill out the Immunoscore form, and it's fairly straightforward, and get it to our pathology department, and then they work with HalioDX to get the specimen sent. In our shop, it's to Richmond, Virginia, which is not too far from our location. And how have you been able to order the test? Is this something that you've used, and what's your experience with the turnaround time?
Yeah, in our experience, from our perspective, we observed that the the turnaround time for the test, it's appropriate for the timely adjuvant chemotherapy prescription. So physicians probably can receive the result of the test in a well managed time frame, so that MDT could take the right decision based on a well documented and accurate result of the patient. A personalized decision making is always what we aim at in all scientific and medical community. So I think that we are very happy with the time around time for our patient when we decided to perform the test.
Thank you very much, Juan and Benjamin. For us, it's really a pleasure to have you and to discuss between the continents to the whole world. This was a very nice opportunity to show to the world that the medical oncology here in Argentina is really an excellent multidisciplinary, transdisciplinary team. So we hope that we can share with you all your knowledge, and let's start with this point, and really this sum of precision medicine could improve our patient outcomes. So really we appreciate a lot. Thank you very much.